My talk is essentially on angular deformities in children, but I shall limit myself to the knee joint, predominantly frontal plane deformities, because this is a wide and vast topic. And the brief essentially is to decide and discuss decision making in frontal plane deformities around the knee joint. What we know is that when you connect the center of the hip to the center of the ankle by a line called as the Mikulicz line, this line should pass somewhere close to the center of the knee joint. What we also know is that when you draw two joint orientation lines from the distal femoral joint and the proximal tibial joint, these form an angle with the Mikulicz line, which is the mechanical distal femoral angle and the mechanical proximal tibial angle, which are around 87 and 88 degrees. You can also draw an anatomical axis through 2 points in the center of the shaft of the femur and the tibia and get an anatomical lateral distal femoral angle or a medial proximal tibial angle. The anatomical and the mechanical axis of the tibia are the same, and hence the two angles are similar. But there are certain things which we need to know. When we see a child coming to us with a deformity around the knee, we need to know, one, is there a deformity for certain, because some of them are really subtle. Second is, where is the deformity? And the third is, what is the magnitude of this deformity? Now let's look at this particular picture. There appears to be a proximal tibial deformity. So if you draw a mechanical axis and connect the center of the hip to the center of the ankle, you will see that the center of the knee is lateral, which essentially tells us that this is a varus deformity. And on a little more further planning, you realize that this deformity is in the proximal tibia, because the MPTA is 69 and it should be around 88 to 89 degrees. So we know that this is a proximal tibial deformity. So what you essentially do is you see on the other side, considering that it is the normal side, and the normal side MPTA is 87 and LDTA is 93. So essentially what you do is you draw the normal angles on the affected side and you get something which is called as the chora, or the center of rotation of angulation. And this is essentially where you need to do an osteotomy to correct the deformity completely. So the osteotomy rule number one essentially is that when you do an osteotomy at the level of the chora, you get a complete correction of the deformity, but you do not have to translate or angulate. However, as you move further away, either proximal or distal from the chora, you do get a kind of an angulation translation osteotomy, wherein you need to angulate and translate the distal or the proximal fragments, and you get a deformity which is corrected, but there is a compensatory deformity which looks like a Z. So this is essentially osteotomy rule number 2. So based upon this knowledge of what we know and what we need to know, how do we decide on decision making in frontal plane deformities? It's very simple. You just need to remember the mnemonic A, B, C, D, E, F. A is the alignment, B is the bone, C is the chora, D is the deformity correction planning, E is the execution, and F is the fixation. Now look at this particular case. This looks like a genu varum deformity. So we need to see what the alignment is. There is a mechanical axis deviation. The knee is lateral to the Mikulicz line, so we know this is genu varum. The bone which is involved, we will have to draw the various mechanical axis and the joint orientation lines. So here the MPTA bilaterally is reduced, that is 82 and 83. So we know that the deformity is in the proximal tibia. And now that we know that, we draw a chora, and the chora comes again in the proximal tibia. You do a deformity correction planning using some sort of a software or app, and this is what it looks like eventually. So we are going to plan and do a medial open wedge osteotomy. How do you execute it? Execution is done very similar to what you do in an HTO. Essentially, this is what it looks like. This is a medial incision, a similar exposure, an L-shaped osteotomy. Connect the osteotomy. It is an incomplete osteotomy which you need to do, and you also need to incorporate an osteotomy of the tibial tuberosity. So it's an L-shaped osteotomy. Once you perform the osteotomy, you put your osteotomes inside, you distract, open a wedge slowly but surely, I prefer for these osteotomies to take an iliac crest bone graft because in my hands they have had the best results, and you can use a Tomofix plate to fix it. So this is what it eventually looks like. Now this is the pre-op and that is the post-operative X-ray, and you can see the clinical pictures as well. The second case is a genu valgum deformity. If you look at the alignment, it is in valgus. The bone, it is the distal femur because the LDFA is reduced on both sides. That is the cora. It is almost close to the distal articular surface of the femur. So you cannot do an intra-articular osteotomy or an osteotomy in the joint. So you have to do it as close to the osteotomy as possible. So here you're going to use the osteotomy rule number 2, which is angulation translation. Now when you do a dome osteotomy, you do a translation across multiple points, and hence the amount of angulation which you need to perform is significantly reduced. So I decided to do a dome osteotomy here because you don't really get a Z-shaped deformity when you correct even large degrees of angular deformities. So this is how I'm going to plan it. That is the mechanical axis, distal femur, proximal tibia. And the plan is going to be a distal femoral osteotomy, which is very close to the cora, and do a dome-shaped osteotomy like this, and slowly get the distal fragment aligned to the proximal fragment. So this is the minimally invasive way by which I do it, and this is what it looks like. And this is the pre-op and that is the post-op. That is the pre-op clinical picture and that is the post-op result. You can do it for a unilateral case as well. Just like a dome osteotomy, you can also use something like a closed wedge osteotomy, and I'll be telling you when I use a closed wedge osteotomy. So this is a child, unilateral deformity, limb length discrepancy. The affected limb was longer, so I decided to do a closed wedge osteotomy and use a medial plate. This is another child where I did an open wedge osteotomy and put 2 grafts from the lateral side. This was done because there was a limb length discrepancy which I need to equalize. This is a third case, a 17-year-old female with a genu valgum. As you see, it's a very, very severe deformity. And look at what the axis is. There is a significant mechanical axis deviation. Which bone is involved? It is the distal femur. The LDFA is around 63 on the right side, and this is a significant deformity. The cora is again very close to the distal femur, and you cannot do an osteotomy there. So you need to do an osteotomy in the distal femur as close to the cora as possible. We did a dome-shaped osteotomy. Despite this, there is a persistent MAD. This was expected, and we had told the patient that she would require more than one procedure. There is some amount of joint obliquity. So what do you do next? You need to do one more osteotomy to get an anatomical and a mechanical alignment. So what we tended to do was we did a proximal tibial osteotomy and got a correction, and eventually that is how it looks like. So distal femoral combined with a proximal tibial, both are dome-shaped osteotomy. The mechanical axis is corrected and the joint lines are horizontalized. Now let us look at a few complex deformities. This is my last case. This is a 17-year-old boy with an open distal thigh injury. This was a proximal tibial physeal injury which was treated 10 years ago with pins and a plaster. The child was able to walk, but he had a complex proximal tibial deformity. Unfortunately, we didn't have any previous x-rays available. So there was a 60 degrees of knee flexion deformity. The deformity was in the upper tibia. There was a 25 degrees of knee valgus deformity with the apex at the proximal tibia. There was a 30 degree of hyperextension of the proximal tibia over the femur, and there was a 3 centimeter shortening. So this is what the scanogram looked like, extremely, extremely complex. This is what the lateral x-rays looked like. This is what the planning looked like. So eventually we plan to do a closed wedge osteotomy in an oblique plane to correct this deformity. So the knee procurvatum was 60 degrees, hyperextension was 30, the angle of valgus was 25, so we decided to do a 25 degree anteromedial plane deformity correction to correct both these deformities, after which we calculated that there would be a 5 degrees of residual flexion and some amount of valgus would still persist. So this is what the correction looked like. This is about 5 degrees of FFD which we stretched out, and a 7 degree of knee valgus, but a 5 centimeters of limb length discrepancy. So the story doesn't end here. You still need to correct these patients beyond that. So this is what it looked like. We decided to do a distal femoral open wedge osteotomy to correct this deformity, and eventually we were able to get not only a complete correction of mechanical axis, but only a 1 centimeters of limb length discrepancy eventually. And that is how the mechanical axis corrected. So decision making in distal femur fracture, in distal femur osteotomies, is that if it is a bilateral deformity, just look at if it is symmetric or asymmetric. If it is symmetric and there is no limb length discrepancy, you can do a dome osteotomy. If it's symmetric with a limb length discrepancy, you can do an open wedge of the shorter and a closed wedge of the longer. In an asymmetric deformity, no limb length discrepancy, you can do a dome osteotomy. If there is a limb length discrepancy, you do an open wedge of the shorter and a closed wedge of the longer limb. In a unilateral deformity with no limb length discrepancy, you do a dome osteotomy. And if there is a limb length discrepancy, you can do an open wedge for the shorter and a closed wedge for the longer limb. Thank you very much.